Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. You're sensitive to your hormones. Let's just start there, but it's not the way you think. And I want to use this episode to help break down the way you feel about your hormones and how they impact your mood so that you can hopefully get better care, not waste your money doing things that you don't need to do with respect to hormonal health, but also to highlight some real advancements in the research on mood and hormones so that you are using the most sort of, we'll call it cutting edge information in your world as possible. I'm Dr. Jordan Robertson, and if you've been around for a while, you know that I've been talking about hormones and mood, testing hormones and the validity or lack of for testing hormones in various regards for a very long time. And the reason I want to revisit this topic is that there's definitely been an increase in the number of people who are aware of perimenopause and hormone fluctuations influencing how they feel. There are more people asking for treatment, and I think that's amazing and incredible, and I want you to be well equipped when you go to have that conversation, that you have what you need to be able to even have a good conversation with your practitioner. And I think that this is an area where we've generally had a lot of misinformation. There's a lot of myth that drives me crazy. And there's some predatory conversations about mood and hormones online that I really want to dive into and talk about. And I'm going to make some of my own predictions. So I'm not going to take credit for this, but for a long time ago, there were whispers in the research about hormone sensitivity being an issue around, I'm going to use the word the delta, which what I mean by that is that your hormone levels change a lot during the course of the month. And the way that people feel in response to their hormones has everything to do with the change and less to do with the absolute number that your hormones reach throughout the course of the month. I will be the first to say that we hate this in medicine. Like, we want cutoffs. We don't want to look at individual sensitivity. We don't want to look at individuals at all. Actually, we would like to take averages, and we would like to look at statistics and say, on average, this is how people are going to respond. We like cutoffs, right? We like saying, like, above this number, you're fine. Below this number, you are not fine. We like saying over here, you're going to be symptomatic, and over here, you're not going to be symptomatic. And yet, that's not what we experience when it comes to hormones and mood, which I think is probably why there's been a delay in us researching this and understanding this, because it's not fitting into this sort of like cookie cutter way that we like to think about medical conditions. And as soon as research starts to say it's individualized, like, systems start to like break down. It's very hard for us to study it. We almost like throw it into a bonfire and say, well, I guess we can't, we'll never know because the response is individualized. And this is kind of how this is played out when it comes to hormones. But maybe 8 or 10 years ago, I started to notice in the research that we couldn't predict who had PMS based on hormone levels alone. So if we tested your hormone levels, we tested all of your friends' hormone levels, we lied out everybody's blood work on a piece of paper on a tabletop and said, okay, we took, the smartest physicians in the entire world who study hormones and study PMS, and we say, okay, here's the lab work of 100 women. Which of these women have PMS? We can't tell you. We don't know. because the absolute numbers of the hormones don't matter. Everybody's hormone levels fluctuate throughout the course of a ovulatory cycle, and we can't tell based on looking at those numbers who has PMS and who doesn't. And yet, if we put all 100 of you on a hormone suppressing medication, right, we just like block it out, Lupron, right, like one of those medications that just put us into sort of a medically induced menopause state. For the people that had PMS before, generally their PMS gets better. Weirdly, a couple of other people now feel terrible because we've lowered their hormone levels, but I'll come around to that in a second. But we knew, right? We knew that the hormones were playing a role when it came to mood, because if we took them out of the picture, most people who had PMS actually felt better. If we started to do very radical things for patients with PMDD, like hysterectomy or oophorectomy, or we started to suppress, again, their hormones with medications and put them in a state of menopause, they felt better, generally. There is a subset that don't, but again, I'm coming back to you. Generally, we feel better if we take hormones out of the picture, and yet we couldn't map it, right? We couldn't say, well, your estrogen levels are X, and therefore you feel Y. We weren't able to do it. And so we started to look at a whole bunch of other things, and you know, are there other neurosteroids or other neurochemicals that are influencing how we feel in PMS? Maybe, right? But the root is it always seems to come back to the impact of hormones. So what do we do with this? Well, we started to have this sort of whisper of a conversation that maybe it was actually about the delta. Maybe for some women it was that their hormone levels went from 0 to 100 miles an hour over the course of a couple of days that was actually creating the problem for them, not that they went up to a particular level. And this is actually now much better researched and much better understood, and we think that this is actually the case, that it's not that your estrogen levels hit a peak of 1300 on your blood work throughout the course of ovulation. It's that they've gone from a relatively low level in that early follicular phase of the cycle to a very high level later on. We also know that the fluctuation of progesterone seems to influence neurochemicals, neurosteroids, and the way that our brain reacts during that luteal phase, but only in some individuals, right? Only in sensitive individuals. Not everybody feels terrible when they ovulate. So why do some, right? But the research started to shift towards us talking about the delta, meaning that in your body, your hormones go from point A to point B over the course of your menstrual cycle. And truthfully, they're going up and down throughout that one menstrual cycle. So it's not like there's one shift in hormone levels, there's a couple, which probably accounts for why like your friend feels terrible at ovulation, but you feel terrible like later on in your luteal phase, is that you're actually having a different response to different changes in your brain. But that each individual person's experience is actually, I'm going to say the issue in air quotes, versus us blaming the hormone itself. And this is incredibly important. And I've actually spent a lot of times talking to clinicians about this, because if we realize this, it suddenly makes us less concerned about testing. It suddenly makes us less concerned about testing. Because if we can't tell you if you have PMS, and we'll talk about perimenopause, etc. in a minute, but if we can't tell if your mood is bad because of your hormones by measuring your hormones, then why are we measuring them? And so I've spent a lot of time talking about this with clinicians, because there are many hormone assessments that are marketed to clinicians and patients alike that we will get to the root of your hormonal symptoms if and only when we do these special hormone tests or we test your hormones. When women read that their hormones are a problem for their mood online, they demand that they want them to be tested. And it creates this conflict because, whether you're a conventionally trained doctor or an integrative doctor, you really shouldn't be testing hormones just for the sake of understanding someone's mood related to their hormones, because again, line up 100 sheets of blood work and we cannot tell whose is whose. So I've advocated quite a bit for us to not look at testing, use the more clinical assessments for PMS and PMDD, which are actually about tracking your symptoms going forward. This has been a big part of my work with clinicians over the last 10 years, is to help them understand that testing is not helpful. Symptom tracking is very helpful. But as we move into sort of this newer understanding of hormone sensitivity, it actually is even more important that we don't rely solely on testing at this point to try and understand why you feel the way that you feel. And for a quick refresher, that right in your period or during that menstrual phase, your hormone levels are the lowest. And what the newest research, and I'm going to call out one particular paper that I'm so pleased with, starts to call out is that one of the reasons we've had such a hard time understanding this and assessing this in patients is that some people feel bad during their period. Some people feel bad during that typical luteal phase or PMS window. Some people feel bad at ovulation. And those are three very distinct hormonal events. Right? There are three very different things happening there. For us to just call it hormones and hormone-related mood issues, we've probably done a bit of a disservice. There are three very clear, very different hormonal events that are happening during that 2 weeks or 3 weeks of the menstrual cycle. And having us understand that deeper is actually probably going to help you feel more clarity around which solutions are going to work for you the best. And then I'm going to talk about where I think the research will go. And this is definitely going to be a prediction on my part around resiliency building, because as we see in other areas of medicine, when people don't feel well during normal biological processes, generally the things that resiliency build, like exercise, actually improve those symptoms. And I'll talk about my predictions a little later in the episode. But during your menstrual cycle, your hormones are the lowest. During ovulation, there is a surge of estrogen, and that is then met with a delayed increase in progesterone. And during that like luteal phase, progesterone levels are relatively high. Estrogen levels come down a bit from that peak ovulatory surge. Sometimes we get other surges of estrogen, like mild surges of estrogen during that second 2 weeks. And then when pregnancy does not happen and there is no egg fertilized, the hormone levels decline towards your period. And so you can see there's these distinct three episodes that are happening. We've got the hormonal surge of estrogen and ovulation. We've got the luteal phase increase in progesterone, and then maybe some mild fluctuations of estrogen. And then we have the relative decrease and falling off of those two hormone levels to menstrual levels, which are typically quite low.
Do you know what I was dying for when I was a practicing clinician? I wanted someone to summarize the latest research, tie it up with a nice little bow, and deliver it to my inbox every single month. I'm Dr. Jordan Robertson. I'm the host of the Real Integrative Medicine podcast, and this episode is brought to you by my free integrative medicine magazine called The Stacks. We're all dying for unbiased, unindustry-funded information to help us be the best in practice. The Stacks delivers you quality articles every single month on the latest research on things you care about in practice, as well as opinion articles and business advice for integrative practitioners and naturopathic doctors. You can subscribe to the Stacks with the link in the show notes today and get access immediately to all of our back issues that show you exactly how to be an evidence-based practitioner. I hope you sign up and you'll enjoy it.
Those three distinct phases, we're suspicious that there are distinct mood-related symptoms that come up during each of those phases. Now, this is really preliminary, so I'm going to share it with you, but if you're like, but I'm angry on day 10, Jordan, just remember that we're trying to tease through and explore areas that are pretty cutting edge and actually haven't quite been studied to the depth that I would even like at this point. But I'm sharing this with you because I think, and I love when studies are published and papers are published when they're starting to confirm a narrative that we could kind of see tying together many lines of research previous. So we know that it's hormone sensitivity, not hormone levels. We know that there's intra-individual sensitivity, that it's not across the board, that all people who ovulate are sensitive. We know that some patients with PMS get better when we put them on the pill. We know that some patients get worse when we suppress their hormones with medication or with surgery. We know that patients who have medically induced menopause seem to fare the worst when it comes to mood-related changes. And so we've known, right? We've known there's this like these pockets of information that we've known all along. And now we are getting to a point where we might actually start to be able to understand it. So what we think is happening is during that luteal phase window, we've always been suspicious that progesterone's a problem. We've always been suspicious that allopregnanolone, which is another neurosteroid that is produced from progesterone, say it in the simplest terms, is some people are differentially sensitive to that particular neurosteroid. And during that luteal phase, it brings up symptoms of irritability, anger, irritation, like that general sense of like a live wire is under your skin. I always loved some of that research on PMS where it's like, and we showed them faces of people and the women in the study thought everybody was mad. Like there is a chemical change that's happening in the brain, and for some people that actually lights on fire parts of their brain that cause irritability, frustration, impatience, right? I will say maybe those air quote typical PMS symptoms. And we think based on what we know about allopregnanolone, based on what we know about this progesterone sensitivity, is that when those levels are high during that second phase and the brain has been kind of primed through ovulation that holy geez, there's a huge hormone shift happening here, that those patients get those symptoms and they have that level of irritability. Funnily, if we get rid of those hormones, right, and so there's been some neat research on if we get rid of those hormones chemically, lupron acetate, which is the drug that sort of chemically induces menopause, if we get rid of them, those patients who have that irritability, they tend to fare better. They feel a little better, right? And if we add those hormones back in, right, so we take away the hormones and then we put the hormones back in, they feel worse again. Now here's the trick. If we put the hormones back in and we leave them in. So remember I said at the beginning that it's the delta, it's the change in hormones, and your hormones change an awful lot during the cycle. If we take away the hormones and we put them back in, but we put them back in at a steady state, the irritability only happens in the first month. And then it stops. So it's the change from 0 to 100 that creates the irritability in that luteal phase. But if we leave those patients at a high dose or luteal phase dose of progesterone and estrogen, their mood symptoms stabilize. They don't just have perpetual PMS for the rest of time. It was the first month that we put them back in. So remember, we medicated them to be low. Then we medicated them to be luteal. And their symptoms in that first month return. They're irritable, they're impatient, they're frustrated, they're PMSy. If we leave them on the meds and we leave them in a luteal state, by the second month, they're fine. It's fascinating because it's not the hormones, it's the delta. It's the change. That's the issue. So that's one subset. That's one group. It's that luteal phase worsening. We generally think there's more irritability associated with those hormones. If we put you on a steady state of hormone, high or low, you feel better generally. And so we'll talk about perimenopause and where this is a unique example in a second, but it's trying to smooth out that delta that generally creates improvement in those patients. Now, the next group is the group that doesn't feel good when their hormone levels go down, okay? When they go down. So the group that doesn't feel well towards the period, right? And as you're coming into your cycle is almost ending, and now your hormone levels are declining because we didn't get pregnant. The symptoms that are associated with that are generally more depressive. So depression, a feeling of hopelessness, right? There may be sleep disturbance associated with all of that, but they generally tend to be low mood versus irritability, which was maybe earlier in the cycle. Now, those patients are responding to the drop in estrogen for the most part. So a drop in progesterone we don't think is actually that consequential, but the drop in estrogen that's happening during that phase actually starts to shift or trigger various neurochemical changes in the brain that make us more inclined towards lower mood, and then probably like disrupted cognitive function. We know this from the menopause research that lower estrogen does for some patients create some cognitive disturbance like brain fog and feeling like a lack of concentration, etc. But that shift that's happening right at the period and actually persists into the next cycle is usually related to those low hormone levels. And I've definitely had patients where, and when we work in PMS and PMDD, we are like looking for this line in the sand where it's like the moment you get your period, the sun comes out, the rainbows come out, everything is great. And then there's patients that they're like, I don't feel that much better. And historically, I would say, I have even said, well, that's not meeting the diagnostic criteria of PMS or PMDD if there is no relief with the period. And although at this moment that's true, what's probably also true is that we're talking about a slightly different subset of patients that until they hit day 5, day 6, when estrogen levels start to like climb back up out of the basement, then they feel better, right? There is definitely a group of individuals who have worsening symptoms when their estrogen levels are low. So I said earlier, right? Like for some of you, if we put you on the pill or if your hormone levels are super low or if we put you on Lupron, you feel worse. This is you. This is you. And this is me. So I deeply resonate with this particular scenario because when my estrogen levels are low, and they've been low at various times in my life for various reasons, most notably when I've cut weight for weightlifting competitions. But when estrogen levels are low, for me, like it's very low mood, but more depressed than irritable. For those patients, if we medicate them, so I gave you a few examples with the last group, right? If we suppress their hormones, what happens? If we put hormones back in, what happens? We've done the same thing with this group. So the group that gets depressed when their period comes, we've tried just giving them estrogen to see what happens, and they're less depressed. We've tried taking their hormones out of the basement. So their estrogen levels go into like basement levels during your period. If for those people that have low mood during your period, if we bring them up out of the basement with estrogen, their mood gets better. Isn't that fascinating? And it wasn't the number, right? So we can't test all these women and be like, okay, your estrogen's 40 and yours is 90. And those are both normal numbers-ish. And neither of those women might feel well and both of them might feel fine. We can't test it. But we know if we supplement back in estrogen, then those women, if they were not feeling well, they feel better. Raising them up because as the fall happens from the previous month, it's the delta. It's did it fall and how far did it fall relative to where it started? That's what creates the sensitivity. So for some people, and these people, I would say that things start to become more prominent during perimenopause because we do get this like episodic low hormone levels during perimenopause, especially as your cycles start to get farther apart, because you're going to get these changes that put you in a low hormone state more often. If you don't ovulate, you don't get that nice estrogen amount. And then you may have months where you feel totally fine because your estrogen levels are relatively decent. I would say that this is where we probably start to see some creeping in of low mood in that perimenopausal phase. And the people that had been sensitive to low estrogen levels prior to perimenopause are going to be the ones most susceptible for an issue when things do start to shift with perimenopause. So that's like our distinct second group. And that might be you, right? You might say, yeah, the pill did nothing, or the pill made me worse, or, I felt amazing during pregnancy. And then as soon as I was postpartum, things were generally worse. And your hormone levels were maybe low, right? During that phase of life, or lower than they were before for you. So that's our second distinct phase. Now, the third phase, which is that like feeling worse during ovulation, is the least well studied. And my favorite paper on this right now, Jessica Peters' 2025. I'll put it in the show notes. She also calls out that this is the group that's been studied the least. And there's like this high suspicion that people that feel the worst during ovulation may also have other underlying mental health challenges, and the ovulation is putting pressure on some of those pieces. Women typically, if women feel amazing during ovulation, they generally feel like chatty, they feel energized, they feel high sex drive. People who don't feel well during this time may have some of those same tendencies, but maybe on the level of like it being pathologized, right? Where they're feeling a bit manic or a bit like risk-taking behavior, or alcohol and substance abuse increases during that phase, which is definitely documented in the literature, that there may be a bit more of a like, I don't know, we'll call it like a high dopamine drive during that time for some people, but it's the least well-studied gang. We know a lot about the people with PMS. We know a lot about the people who have hormone-related depression during low hormone states and also during the menstrual cycle. We don't know that much about people whose mental health suffers during ovulation. But if that is you, just a food for thought for you, that is there an underlying mental health challenge, whether that's bipolar or ADHD or something, when there's an impulsivity and there's a component to it that when we get that super high estrogen, that it actually puts some pressure on those systems for you that are already a little at risk. So that's the third one. So there are three domains, right? There are three areas that we need to consider. And for you, as you're listening, maybe you hear yourself in one of those. Maybe you actually hear yourself in two of them. And this is where we've struggled with the research. It's like some patients with PMS and PMDD actually don't feel well like a lot of the time. And so we haven't been able to like separate those two things very well, because some people don't feel well during that luteal phase, and then some people don't feel well during that low hormone phase of their cycle as well. So, trying to delineate between those two has been tough. I also think in patients with PMS, perimenopause, and PMDD, we're often looking for a silver bullet to support them when they actually may need a layered approach in order to feel their best, right? So like I said, there's people that don't feel well because of low hormones. There's people that don't feel well because of their high hormones. So what are we going to do, right? If you're both of them, are we going to lower them or are we going to raise them? So if you've sought some kind of therapy and solution and treatment and you were only partially relieved by it, it may be because it addressed part of your challenges and not the whole thing. Right? So food for thought, and just put that in your back pocket, because you're going to be offered, especially if you try and deal with this conventionally, you're going to be offered the pill. An IUD won't help because you'll ovulate through that, most of you, and that won't solve the problem. It'll solve your heavy bleeding, but it will not solve your mood challenges to have an IUD. You may be offered the pill. You may be offered menopause hormone therapy, which we'll talk about where that fits. But they don't really solve some of the underlying challenges with respect to your sensitivity to ovulation. So we're probably going to get a partial improvement for most of these things. And that's annoying, right? We want to be perfect. We want to feel our best all month long. It sucks that even the best solutions that we have for you might only cover part of your symptoms, or may only cover part of your symptoms partially. Like, it's super annoying. But let's talk about hormones as a solution for a second here before I dive into what I'm going to say is my big 5-year prediction on how we support mood with respect to hormones. So the evidence is pretty clear that suppressing ovulation helps people who have that luteal phase challenge, right? That irritability and frustration. Generally, people feel better. I am not going to touch with a 10-foot pole this discussion about whether the pill makes people feel bad or not. I'm just saying statistically it does improve mood, especially if people are high risk, or if we're worried about their mood, or if their mood is really significantly getting in the way of their life. I'm very much let's fix your mood now, work on the basics, and then if we can remove the support for your mood later, fine. But I find too often we we try and like pull patients along trying to use natural treatments for their mood. And then it turns out they can't execute on the entire rest of their treatment plan as a consequence of that. I would much rather have people's mood improved like as much as we can immediately, and then circle back to all the foundational things that they require in order to build resiliency and better health, and then get rid of the thing that was helping their mood. That would be my preference. But the pill does improve it, right? Decreasing ovulation does improve it. Where we struggle is when we're trying to use HRT in patients who are still ovulating with some level of consistency. And I won't say it's a problem because it's dangerous. It's not. I'm actually very much in favor of using HRT to buffer the hormonal changes that happen during perimenopause. Some months in perimenopause, you're going to make lots of hormone. Some months in perimenopause, you're going to make none. And remember I said at the beginning, it's the delta. So imagine if you're a patient who already is sensitive to hormone fluctuations, and now we've got you in perimenopause. Some months you ovulate normally and don't feel well, and then maybe don't feel well when your hormone levels lower after, like in your period. Then we have some months where you maybe ovulate twice. So then you don't feel well twice. Then we have some months where you don't ovulate at all, and now your hormone levels are generally on the lower side. We skip a period and you don't feel well again. When we add HRT, it's not medicating you to the level of luteal level hormones, right? The progesterone gets a little close because we're using progesterone to protect your endometrial lining for the most part, but we're not medicating your estrogen to like peak ovulatory levels. I always used to say to my patients, we're not medicating you back to being 21, and thank goodness, because we don't want to do that. We don't want to go back there. What we're doing is offering a daily low dose support that buffers the fluctuation of hormones. It will not stop you from ovulating for the most part. Most patients will ovulate through their HRT regime when they're perimenopausal. And that can be frustrating because it probably means you still have some symptoms. And it can make people feel like their HRT isn't working. The purpose of your HRT is to decrease the delta. It's to decrease the difference between your high state and your low state by bringing up your low state a little bit, right? It's taking you out of the basement. You may ovulate anyways, but now the difference between your HRT level and your ovulatory level is less. The difference between those two states is less. And we think that's why we're seeing an improvement in symptoms in people during perimenopause when we add in HRT. It also decreases the low states, right? So if you were one of the people where depression or the low mood was creeping in during your period, by having low dose daily hormones, it actually decreases the low times of the month and prevents you from having those low symptoms or low mood. I said earlier that if we medicate people through their period, we actually decrease their suicide risk. We decrease some of the symptoms that they're having during that window. The same is true when we put people on HRT that are in perimenopause. We've decreased the low, right? Or maybe we've increased the low. You know what I mean. We've brought their hormones up out of the basement, which means you're less likely to have those low symptoms between periods or when you get your period, when typically those hormone levels are low. So that's how you're going to treat it. Now, there are lots of other natural solutions for PMS that we're not going to go into here. There's a calcium conversation that I love. I think there's room for things like fish oil. There's room for things like chaste tree. If you're not a candidate for HRT, or if you don't want to use HRT and you just have PMS, lots of options there for you. I don't want to go into that, but really the purpose of that conversation is to say that it's individualized, your response to your hormones. Medicine's not really equipped for individualized medicine, and your use of hormones, whether that's the pill, whether that's HRT, might also have to be individualized, meaning that you may take it for part of the month, you may take one of the two hormones, you may take both hormones but only part of the month. Like, it has to be individualized because we've acknowledged that your mood is responding individually to your hormone fluctuations. But the last piece that I want to mention, and this is really just my prediction, honestly, is that anytime we see in the literature when people's bodies are responding unfavorably to a normal bodily process. And this happens in like POTS, this happens in lots of scenarios where the body actually is having an abnormal response to a normal biological process. It usually means that there is a resiliency component to what we're talking about. And like I said, I am making a prediction. So as evidence-based as I am, I've been watching this literature for a long time. I think in 5 years, we're going to say the greatest solution for PMS is exercise. Because what happens when we build resiliency in the brain is that those normal biological processes start to be perceived as non-threatening. Because right now, if your brain is responding with a absolute catastrophe level, category 5 alarm bells when you ovulate, there is a component to your brain and your resiliency that is over responding to a normal scenario. And when we look at, what sets us up for worse mood during PMS, perimenopause, postpartum, we're often talking about the same risk factors that increase our risk of PTSD, depression in general. And it's often things like trauma, it's things like neglect, it's things like adverse childhood events, right? It's stress. It's things that actually change the way the brain feels about the safety of the environment that actually worsens PMS. Those are our risk factors, right? Our risk factors for PMS are not hormonal in nature. Our risk factors for PMS are actually situational and environmental triggers that then prime the brain to be in a state of fear and to actually perceive that the environment around it is unsafe. And so then that delta, right? Delta is the word of the day. The change in hormone levels from steady state to high levels, or from high levels back down to low levels in a brain that is wired to believe that the world is not safe, right? The symptoms that are coming as a consequence of that are PMS, PMDD, are things like perimenopause-related mood changes. Whereas in patients who don't have those risk factors, don't have the trauma, don't have the PTSD, they actually generally fare better to those hormone transitions. So how do we treat it? Right? And when we look at how we build resiliency in those situations, it usually comes down to things like cognitive behavioral therapy and then building physical resiliency, because we want your brain to believe that the world is safe. And partly the way that we do that is through resiliency building exercise. So my big prediction is that I love HRT. I think that's going to be something that never goes away in women's health. It's just going to get better and better and better and more refined and more individualized and more customizable, especially if mood is your challenge. But I'm going to say this right here today on the Real Integrative Medicine podcast, that in 5 years, we're going to call exercise the greatest gift you can give your mood as a person who ovulates, and that exercise will be the number one treatment for PMS and maybe even for mood and perimenopause.
That's it for today's episode of the Real Integrative Medicine podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.